Hello, everybody. Welcome to the latest edition of the Asia Ventilation Forum, or the AVF ICU Tips and Tricks series podcast. My name is Jason Phua, and today we are really glad to have Dr. Brenda Pun, who's going to talk to us about how she cares for family members of the critically ill. Hello, Dr. Pun.
Hello, thank you for having me.
I'll quickly introduce you. So Dr. Pun is an advanced practice nurse with a special interest in critical care, who serves as the Director of Data Quality at the Vanderbilt Critical Illness, Brain Dysfunction, and Survivorship, or CIBS Center. She's a key leader of the 2018 Clinical Practice Guidelines for the prevention and management of pain, agitation, sedation, delirium, immobility, and sleep disruption in adult patients in the ICU, or PADIS, and in the implementation of the ABCDEF bundle. Her research has focused on improving the care and outcomes of critically ill patients, with a special emphasis on delirium, sedation, long-term outcomes, and teamwork. So, Dr. Pun, maybe the first question for you is, could you share with us what is the immediate impact of critical illness on family members of patients in the ICU?
Well, I think that's a big question because it varies. That the impact on patients and their families of critical illness, so the whole impact can be very dependent on that patient and family and the degree of critical illness and whether it was a planned surgery versus a traumatic event versus a horrible burn, an unexpected situation versus a long chronic illness that is there. But from what we understand in the literature now is that there's a significant impact on patients and their family members, and in a variety of ways. And I think that I would love to use the framework that's used by the post-intensive care syndrome, so PICS, P-I-C-S. And in that framework, which I think it's really helpful to use, it reminds us that it's not a simple answer, that it could be physical problems, it could be mental health struggles, it could be cognitive impairments. And patients and their families can struggle with those to varying depths and degrees.
Right. And these three issues that you talked about, physical, mental, and cognitive, it applies to patients, but it also applies to family. Is that what you're saying?
Right, exactly. So when we look at the impact of PICS or the time in the ICU on the patient, we understand that better, right? We understand, they're going to leave probably with some physical problems, surely some mental health things, maybe depression, anxiety, struggles. They might leave with cognitive impairment and have some kind of cognitive impairment down the road that doesn't quite go away, or at least takes a long time to go away. But we have to be really careful to make sure that we include the family there, that families leave, and in fact, there's a PICS-F for family, is in the original articles. It's like, don't forget, PICS-F is real. And what we see in families is not so much the physical, although sometimes the emotional and the cognitive can take a toll that it turns physical. But what we see is anxiety, depression, the stress of caregiver burden, of being the caregiver suddenly, of a loved one doing things they hadn't anticipated doing, being the primary breadwinner, as we would say, or the one that is making the income when maybe the loved one that was the critically ill patient was the one that worked. So there's this anxiety, this depression, the stress, maybe even PTSD, so post-traumatic stress disorder, from the fear that they had or the intense anxiety of watching their loved one go through this near-death experience, or severe illness, a prolonged illness that was in the ICU. And we also see that with patients, family members of patients who survive. So our family members of our survivors, and our family members of those who die in the ICU. And so those that die in the ICU, same things I just described, but also could be complicated grieving, really not processing what happened, not knowing how to process what happened in whatever it was that unfolded. And I do believe that the pandemic has exacerbated all of this, has added layers or challenges on that has made all of those things more complicated.
Right. And how soon do these effects set in? I mean, this is a very general question, but is there a way to tell, like a few days into the ICU, after the discharge from the ICU? Do you actively look out for it and the timing?
Yeah, so I would recommend that everybody's vulnerable. So every family member is vulnerable to it. So I just assume that it's going to be a challenge for everyone, because most of our families and their loved ones, family members and their loved ones, the family unit. And let's pause for a second and say family is a really broad term here. That family is not just somebody that's a blood relative. So it doesn't be a mother or a brother or a father or spouse. Family is anyone that patient considers family. We can say, so there are many friends and or extended family members that would be closer to them and be their caregiver when they go home. And so you think of whoever has showed up to be in the room there is the family member for this patient. So when we're using that, it's a very broad use of the term. But when we think about how soon it happens, I really think that it could have started for patients, for family members before they arrive, because they've been dealing with for, depending on which patient ICU we're in. If it's a medical ICU, something's been going on with this person likely before they even got to us. So this family has been dealing with this at home, that this loved one has had a complicated pneumonia, something has been happening at home. Maybe they have some chronic illnesses that are decompensating. So they've got chronic heart failure or chronic diabetes or COPD, something's going on at home. And now they have this acute illness on top of it. So the stress has started long before we meet them for many of them. Others are in shock because something emergently happened to their loved one, that maybe they live in another state or far away, and they've rushed to the hospital because their mother or brother or whoever has had a heart attack or a stroke or an accident, and now they're in the ICU, or they got COVID and now they're in the ICU and they hadn't seen them in a very long time. So I think that the stress that can really be putting this pressure on the family can be happening long before we see them. So I think we should assume they're all really fragile. They're probably not nurses and doctors. They may be, but even if they are, these are not their usual patients. So there's a big stress of it all, that my loved one, who I don't normally see this way, looks this way. And also, we're in a different environment that speaks a different language. And they're saying things so fast and so overwhelming. So I really think that we should consider all of our family members are in a very vulnerable and fragile state when we meet them.
Right. You were a key leader of the PADIS guidelines, as well as implementing and studying the ABCDEF bundle, where F stands for family. Could you share with us the components of this bundle and then maybe talk a little bit more about F?
I would love to. So think of the A to F bundle as really as a framework to help us have a structure, checklist, if you will, for doing recommendations on our patients. And so putting those guidelines into practice. It's more of the booklet, the how-to, and the guidelines are what you should. And so when we think of the A to F bundle, it includes A, which focuses around pain, assessing pain, managing pain. B is both breathing trial and awakening trial. So putting those two things together daily for our patients. C is choice of sedation. So choosing wisely and making sure we target light sedation. And D is delirium. E is early mobility and movement, and then F is family. And the reason that, so that bundle is really built on the back of the PADIS guidelines. and the patient and family-centered guidelines. So it's really two guidelines from the Society of Critical Care Medicine that the bundle really is, form the foundation for the bundle. And in the F component, it's family engagement and empowerment. And so I think that that's a really, I love the wording of that, is that it's not just family involvement, but it's engagement and empowerment. And so I think that goes a little bit deeper. But those are the components of the whole bundle, and they're all built on those two guidelines.
Right. And so how do we care for patients how do we care for family members or loved ones of patients when the patients are still in the ICU? Engagement, I can understand. I'll talk to them, engage them. Empowerment, I struggle a little bit. So what do we actually do?
So I think that it's helpful to think about three things. And I think that when we think of this family engagement and empowerment, I think we can think of presence, engagement, empowerment. So door open, conversation, seat at the table. So follow me. So in order to have engagement and empowerment, you got to have family present. So it really starts with a foundation. It's assuming your doors are open, that you allow family, you have open visitation, you have a space for family to sit, to spend time. So there's this presence, family presence has to be. Now, that's challenging in the midst of COVID. And we got to talk about that, right? Like we can't talk about this as if we haven't had a 2-year pandemic. And so that presence may be in person or virtual, but you've got to figure out ways to connect with the family, or there's no way you can engage them and you can empower them. So that's the first one, door open. So have a picture in your head of an open door. So that's family presence. Now engagement, you already mentioned that, engaging them. So if they're there, don't ignore them. Just having them there is not enough. It's engaging them. It's talking to them. It's asking them preferences, wishes, engaging them to be involved, giving them an orientation of your unit, what's going on, providing education that gives good suggestions on what they could do, teaching them what's happening with their loved one. Truth is, they're the ones going home with this patient, right? They're the most continuous thing that will happen in this patient's course. So really providing regular updates to them or discussions, calling them to update them or inviting them to be a part of rounds that they get the updates. So that's engagement. Think conversation bubbles, okay? Presence, open door, engagement, conversation, and then empowerment is really, I call it giving them a seat at the table. So when we think of a boardroom or the important people, they all sit around the table in meetings, it's making sure that we have a seat, figuratively or literally a seat for the family members, like really inviting them, making sure they know they belong in the discussions about the patient so that there is shared decision-making, there's conversation, that their concerns, that they're able to represent and advocate for the patient, that they're able to understand what's going on. And I think that's really powerful for our patients for two reasons. Number one, it makes the patient a human to us, right? We sometimes have this deeply sedated patient that really becomes a name and a number. And to fight against that, to bring a lot of humanity back into it, when we talk to their family member, they tell us, oh my gosh, his nickname is Buddy. And he has a giant German Shepherd dog that's his best friend in the whole world that he's never been apart from. Or he has 15 grandchildren and they all love him. Or he worked for a long time as a fighter pilot. Or and the person sometimes you're like, I had no idea, because I'm just seeing this sick person that's swollen, drooling, that really is, and so it's bringing a lot of humanity into our discussion. And it's also, they represent the patient's wishes and life and desires. And so when families present, engaged, and empowered, we equip them then to care for this loved one, to understand what's going on, to help the patient unpack it later, to help the patient understand what's going on, but also to make really hard decisions. We ask the families to make really difficult decisions. And if we have them present and engaged and empowered along the way, they're better equipped to make that decision. They might see and understand when we say there's nothing more we can do. They've been there. They know there's nothing more we can do. The best thing right now is to provide comfort care for this person to have the best death experience that can happen. They also understand when we say, hey, I think there's another thing we can do, that we can try, or we're going to have these milestones or those milestones. And so having them present, door open, engaged, talking to them, and empowered, give them a seat at the table. They belong there. Are really, I think, the ways to really do that F component.
I think that's a superb reminder for many of us. I mean, despite the guidelines from SCCM, I think anecdotally, all of us have seen, myself included, practices that are completely contrary to what you have said, right? Because of bandwidth issues of the ICU healthcare workers, because of COVID, we sometimes treat family members and loved ones as pests, as parasites, like do not come near the ICU. We have no time for you. We are looking after a very sick patient. Please get out of the way when I'm doing my rounds. And presence, engagement, and empowerment unfortunately become an afterthought, and it should not be. Should not be. And the other thing that we don't do very much of is when the patients are finally discharged from the ICU, and we assume that everything is okay, partly because we only look after patients in the ICU. But as you said, this whole thing about PIC as family can happen anytime in many family members. And so how do we then look out for them after the patients have been discharged from the ICU?
I really think that starts in that engagement part that we talked about. So during the engagement, ideas for how we engage them are providing education. And many ICUs that I've worked with have created a brochure. And I know many of us want to be paperless and we want everything to be online. And it's great to build that out, but it becomes really overwhelming. And sometimes your device is not going to work wherever you are, or patients don't have smart devices. So I really like still having a pamphlet for the families. You can have them online and be able to print them for the ones that you want to give them to, but printing, giving them something in their hand. And many of those I think are excellent ideas. They say something like, welcome to the ICU. And it's a little bit of an orientation. So maybe when you open it, the one side will be, here's the different, here's a picture of the patient in bed and different tubes and stuff. And this is what they're called, just a little schematic. Some of them will have words with definitions beside it. If you hear us talking about a breathing trial, this is what that is. Here's, just some helping to understand the language. But I really think that it'll have visiting hours or how to reach us, that sort of thing, like welcome to our ICU. Here's some basic things we want everybody to know. But one of those basic things should be what to do after the ICU. So at our website, the CIBS Center website is icudelirium.org. And in that website, we have a whole portal for patients and families. And in it, we have actually a patient and family brochure for delirium. And we give that to a lot of our patients and families when the patient is delirious, and we'll give them this brochure. And it helps them to understand, oh, this is what's going on. This happens to a lot of people. Sometimes it can be linked with some long-term problems. If you have some of that, so just A, teaching them these things may happen, and then B, whatever your system has, if this happens, reach out to your primary care provider. Reach out to your, to our hospital has a call line. Many years ago, my mother had a cardiac cath. And same day, she goes home from the hospital. You know, she has this interventional procedure, goes home from the hospital, is at home. And the next day, there's a phone call. Are you taking your Plavix? Have you made an appointment with your primary care provider? 4 days later, there's another phone call asking about something else. How are you doing? Following up. How's your wound site? And I thought, that's amazing. She had a cardiac cath. I work in an ICU where people almost die every day. Nobody ever calls them. There's no follow-up phone call after they leave us. It's bye. We're glad you left the ICU. And then they leave the hospital. There was no system for following them after the hospital. And so that led us to say, you know, should there be somebody in the ICU that just touches base, or somebody in your hospital system, a callback number? Hey, we're just calling to make sure, you know, don't forget, you should really get in touch with your primary care provider. If you don't, here's a number at our hospital that helps you find a primary care provider, or here's a callback number or something like that. So I really think letting them know these things may happen for the patient and the family, and then say, here's a way to touch in our system, whatever our hospital is, whatever you have set up, here's a way to get help if you need it. So it's letting them know, it might have, pointing them to websites. We have so many people that reach out to us and say, oh, I came to your website and I watched all these videos that you had from patients and their families, and I read the stories on the patient family side, and finally, I'm not the only one. I was thinking I was the only one, and I'm not. And so pointing folks to websites like that can help them feel less isolated, less alone in whatever the struggle is they're having. Support groups are an excellent example of that. We have support groups for patients, but patients and families that can get engaged and involved in them. So I think that it really starts in that engagement part of before they leave, say, these things may happen. And if they do, ... whatever your system can handle, check out these resources online, or come back to our support group, or any of those things, I think are great ways to point them. If it happens, here are helpful places.
Right. And you also mentioned just now that there will be patients who die, right? And so they don't really leave the ICU to the hospital, they leave the ICU to the mortuary. So how do we then look after the family members of these patients?
Well, one hospital that I worked with had something they called Code Lavender. And I thought that was a really creative way to say this. We have many codes that we call, and we have some unofficial ones sometimes that we joke about in the ICUs. And this one was called a Code Lavender. And whenever there was a family member or a patient that was dying or had died in the short time frame, they had a pack of things that they would already initiate. So their approach was to be proactive about the death experience. So they wanted to be systematic about that. So, you know, some bedside nurses are really, really, really creative. Others are very, very analytic. And so depending on which nurse you might get a different reaction in that situation. And so they really wanted to make it systematic in their unit. So every time there's a death, they call Code Lavender, and there would be a whole little packet that came out that was already pre-made. And this packet would have some snacks, little snack bags. It would have a music player with some choices of music that they could play. It would have drinks, tissues. It would, it just was part of, and a little checklist to remind the nurse, hey, let's make the environment one where they can all be with their loved one. They can have the time they need. They can walk through this. Let's call our spiritual services, what that might help them walk through this. But let's be proactive about it. That's one way, is to be there, to be proactive about the death and dying experience, to walk with them through that, to mourn with them as they mourn, because sometimes we've built relationships up with the families and the patients, and it's heartbreaking to us. And for them to see that, it's really beautiful. Another example is a hospital that I worked with. They also created some type of memorial token that was given to the family. So they purchased, I don't know where they got these, but these stones, and that I think they were really for children. They were like a children's play set, but it was to put a handprint in something. And so they got those and they did this handprint and they gave those to families in their grieving process. So and the families loved it. They were telling me how the families just loved this. It was such a special token to them. They'd have something. And the third thing is, again, saying grief can be complicated. If you struggle, here's a number. And many of our hospitals are associated with hospice care centers. Now, those care centers are amazing at having post-death support groups. So survivor support groups for those that the spouse, the family, whoever. And in our hospitals, it would be wise of us to say, hey, maybe we should connect with them. And if we have loved ones, if we tell families, if you're struggling, here's a support group you could reach out to, or here's a group you could reach out to. If you're finding, because it happens, grief can be really complicated. And so again, it's just letting them know this could happen. You might not be feeling it right now, but I'm going to lose contact with you. And I want you to go home with this, knowing in a month, when your life is coming apart and your mind is coming apart, you have this piece of paper that reminds you there's a support group out there for you. I think those are some ways, making the experience the best we can make it, and providing some touch point of follow-up or pointing them in the direction of where they could get help.
Right. I've heard of people saying that they need to see evidence that in the scientific literature that some of these interventions that we mount actually work. And yet, you wonder whether you really need to see evidence for something as human as what you have just said, right? What are your views on this?
Well, I think that the research world continues to evolve, right? Like that there are more and more research being done in this area with patients' families. Many of our studies now, we involve the family members as well, and we do caregiver burden assessments. We do employment questions about what is the impact on. I don't know the exact statistic, but there's some statistic that maybe a third of family members or caregivers are no longer employed at the same level they were before the patient was ill, because they've become this caregiver. And in the caregiver role, you miss work because you have to take your loved one to doctor's appointments because they can't get there themselves. You miss work because they're sick and they need someone to be there. It's almost like caring for children and parents that need that type of leave. So there are some data there that point to those things, and usually it's the economic loss that we see data about, is that economic loss. But there's more research, where the more long-term research that we're able to do on these ICU patients, which is just blossoming, we see the families are being involved in that, looking again at caregiver burden, at anxiety, depression, all of those things with them, for reaching back out to to family members of patients who died or had maybe a traumatic death in the ICU, or more of a traumatic death or unexpected death in the ICU, to looking at PTSD and those types of things in family members. It's still small, and I would point all the listeners to the you can search family-centered guidelines, SCCM, and you'll find Judy Davidson was the lead author of those, and it's a great starting point for evidence, because there's a lot of little studies, but when we put them together, we can see, hey, these are all pointing towards this concept, or these of open visitation. These are all pointing to the process of engagement and empowering, involving family in rounds. I see journal article after journal article now about family in rounds and the effect that that's having on the trainees or the attendings or the families or the nurses, and what that's like, whether it was a good thing for the family or a bad thing, interviewing the family. So I think we're seeing more data, but it is helpful to find a common place to start. And I think those guidelines, going to that reference list of the guidelines, is an excellent place to start, because they've done the work for you up to that date. And so it's a great starting place.
Right. Thanks a lot, Pun. So in summary, you have shared a lot about the impact of critical illness on loved ones of patients in the ICU, about the two different SCCM guidelines, the A to F bundle, about what we can do when the patients are still in the ICU for the families, as well as after discharge, as well as after or before death. I honestly, I'm dying to show some of my colleagues this video so that we can take some of your ideas and see what we can do in our own ICU. And I'm sure a lot of the listeners out there will be doing the same thing. Any last words, final words you would like to share to our listeners?
My final words would be that I think the pandemic has done considerable damage in this area. And I think that we closed our door. If you think of those three things, presence, engagement, and empowerment, we closed our doors. We took away the conversation because we were busy, we were swamped, we couldn't talk to anybody. We barely were surviving as clinicians and taking care of patients in these surges. And the empowerment was completely gone. Number one, because family members may have had COVID as well. They may have not been able to make decisions or be present or be a part of that. They weren't being invited in to have a seat at the table. They were at a distance at best. And so I think that we're all in a state of reset right now. Or I saw something the other day that said resurrection, that can we resurrect these best practices in the A to F bundle, including the F from before the pandemic, and provide this quality of care, this guideline recommended care to our patients and their families, and reset ourselves back to standards. And I think that this is particularly an area that suffered. And the last thing, we did a study at the beginning of COVID called COVID-D. You can Google it, COVID-D. It was in the Lancet Respiratory Medicine. And in that paper, we were just looking at risk factors for cognitive impairment for delirium. And we saw that, not only were our patients on gobs of benzodiazepines and other sedatives for long periods of time, and we saw that to be predictive of delirium. That, and no surprise, right? We already knew that. But here we are giving these huge quantities and for long periods, and we're, and so hopefully we're resetting our sedation ways. But we also saw that there were only 8% of 20,000 patient days. Only 8% of them had a family present. Only 8% of the days. Now, if we widen it back out to virtual, then we get up to 17%. Less than 20% of 20,000 patient days had a contact with a family member. But when that happened, it was preventative for delirium. And so even in the midst of the pandemic, when the doors were closing, the conversations were going away, we were reminded this how important family is to be a helper for our patient outcomes. And so it's just a reminder that all of these things, COVID has really derailed a lot of our best practice, and we do need to resurrect, reset our standards from before the pandemic and have those doors open, get those conversations happening, and invite the family to be a part of rounds, to have a seat at the table.
Thank you. And on that very inspiring note, and after 2.5 years of terrible times in the ICUs for all of us, our patients and our families, it's time for, yes, the resurrection. So thank you again, Dr. Pun, for spending time with us. Thank you.
My pleasure.
And for all the listeners out there, this has been the AVF Tips and Tricks podcast. It can be found on YouTube, on Spotify, and please feel free to share it with your friends, to like it, to subscribe. And see you next time. Take care.